you hear me, Harshil? Oh, yeah, I think put up the slide first, my first slide, and then admit people. Okay, thanks. Okay, Harshil, just put up the first slide. Let's get started. It was up there before, now it's gone. I can see the slide, yeah, now, okay? Okay, good afternoon, everybody. Harshil, can you hear me? Okay, I'm requesting everybody to switch off their mics so that we can start the talk. It's 12 o'clock. If there are any problems, then you send a text message to Harshil on the chat box, okay? Otherwise, if I don't see anything on the chat box, I will assume everything is going fine. And Harshil, you can call me on the phone if there are problems, okay? Can we get started? Okay, good afternoon, everybody. My task this afternoon, is to cover pre and post-operative care with you. As you all know, I'm the professor with the Department of Surgery, University of Nairobi. That's the first slide. Next slide. Okay, as an introduction, all right, for pre and post-operative care, what is the main issue? Okay, you're going to perform surgery. That's why you need pre-operative care. Surgery cannot be made risk-free, but risks must be known so that the patient can make an informed decision. If you're going to be operated, you need to prepare the patient, and one of the things is an informed decision from the patient. Surgery anesthesia complications are common, they are not rare. If you look at the amount of complications that occur in the US with surgery, 15 years ago, one full load of 747, Boeing 747, equivalent number of people, 354 complications occurred every hour. These are associated with increasing morbidity and mortality. So surgery should not be taken lightly. And preoperative evaluation, planning, okay, is very important because it not only develops a plan of anesthesia care, but also optimizes patient for surgery. minimizing complications. So the idea of pre and post-operative care is to make sure that there's somebody whose mic is on. Please switch off. Ariel, you want to switch off your mic then? Next slide. So with pre-operative preparation, how do you start? You need a detailed history from the patient, all right? And I'm not going to go over history taking, but the steps of history taking, the general information, the chief complaints, the history of presenting illness, past medical history, family social history, drug history, systemic inquiry, all those things become very important. And especially in your past medical history, a history of general anesthesia in the recent past is very important. The physical examination must be thorough and complete. You can't imagine how important it is to examine a patient thoroughly, each system in a detailed manner. Then his current drug treatments are important, laboratory investigations are important, and specific investigations pertaining to what this type of surgery is. If a patient is going for a surgery for his jaundice, obstructive jaundice, then there are coagulation problems, and you need to correct the coagulation whatever disorder occurs, and you need specific investigations like INR, platelet count, and things like that. Next slide. So detailed medical drug history is very important. Gather and record all relevant information. What is the current condition? Prior surgery, I mentioned, anesthesia, allergies. Optimize the patient's condition. Choose surgery that offers the minimal risk and maximal benefit. So if you have a patient who is old, who is obese, and has gallstones, you do not want to do an open cholecystectomy. You want to do a laparoscopic cholecystectomy, especially in such patients, if not in all patients who need a cholecystectomy. So choose surgery that offers minimal risk. Anticipate and plan for adverse events and inform everyone concerned. We'll come to the consent taking later on. Next slide. So it's important that the past history of diabetes is taken because the patient could go into hypoglycemia when you're operating the patient. This is important because it also increases the risk of perioperative complications, infection, stroke, myocardial infarction, renal disease, and glycemic optimization is key. In fact, at the present moment, reading an article yesterday, every patient going into theater must have a reflow, blood sugar checked before he enters theater, okay? Because if you look at Kenya, for example, okay, the number of diabetics which are there who are undiagnosed, half of them don't know they're diabetics, okay? So you'll pick them up at such things. Obesity is important, renal disease is important, smoking is important, and current medications which they take. You need a detailed history, and you need to know about drug interventions. Next. Examination, I mentioned each system. Can you get me a glass of water, please? Huh? Sorry, that's talking to my office manager there. So physical examination, you need a physical examination of the central nervous system, cardiovascular system, respiratory system, upper airway examination, even if you are examining the abdomen, okay? Next slide. Even if you're going to operate on the abdomen, you need those, okay? Pre-operative laboratory data. Now, these are important and very relevant and vary from patient to patient. So if I'm going to operate on Harshil Patel tomorrow for his hernia, and I do a good history, take a good physical examination, I may not need any investigations. If clinically he is not anemic, all right? I find that there are no problems with him. He's unlikely to have a family history of diabetes or anything. There may be no investigations required, okay? Now, I'm an experienced, brave surgeon, and I could do that. But the recommendations are not that. Recommendations vary from country to country. Some countries say you must have a hemogram and urea electrolytes. Some countries say that you must have hemogram. But you have to be smart in trying to say what outcomes do you want to expect and how will you manage those. And according to that, you're going to have your pre-operative laboratory data. But in general, all patients who are on diuretics must have potassium checked because you know furosemide causes hypokalemia and that can have effect on the heart when you're operating. Glucose is important in diabetic patients, as I mentioned, hypoglycemia. And patients who are suspected of losing blood must have a hemoglobin taken. So when I do my hernia, the blood loss may be 30, 40, 50 cc's, maybe 100 cc's. And if your HB is okay clinically, then I could operate you without even a hemogram. But it depends on the surgeon. But the guidance, if you get into problems, then medico-legally, you won't be covered if you don't have the investigations. For otherwise healthy patients, preoperative laboratory testing are not needed, as I mentioned, and tests done in previous 6 months may be sufficient, or even before. ECG in all symptomatic patients and asymptomatic men, 48 years or older, women 48 years or older, or men 50, women 50 and men 45. These are the guidelines for doing ECG. Then urine pregnancy testing should be performed on the day of surgery in all women of childbearing age. These are some of the important things that you need to take note of. Next slide. Okay, I mentioned potassium in diuretics, blood sugar in diabetics, chest x-ray if there is chest disease. If you're greater than 50 female, you need ECG. 45, greater than 45 male, you need ECG. So those are important things. And if you have asthma, obesity, or pulmonary disease, any other pulmonary disease, COPD, you need pulmonary function test. So it depends on what the patient's history and physical examination shows, then you do the tests according to that. Next slide. So if you tie all these things together, what are you trying to do? You're trying to do a risk assessment, okay? An 80-year-old man who's diabetic, who has got asthma, okay, is a high-risk patient, as compared to our Harshil Patel, who is maybe 22 years old and has a hernia in the right groin. So you're doing a risk assessment. You want to look at all the data from the history, the exam, the labs. Is the patient in optimal medical condition for surgery? All right. Are the anticipated benefits of surgery greater than the surgical anesthetic risk associated with the procedure? All right. What are the tools do we have, other tools for risk assessment besides history, physical examination, and labs? All right. So the American Society of Anesthesiologists, right, have a physical status scale which correlates well with anesthesia of risk and surgery. Next slide. So ASA classification, ASA stands for American Society of Anesthesiologists, okay? That classification will look at the risks, but age and difficulty of intubation are excluded. Next slide. So basically ASA classification says that if you are somebody like Harshil Patel, who is a 24-year-old or 22-year-old young male with no associated medical conditions, all right, and no other problems, then he is a normal, healthy patient, all right? So he's ASA classification 1 or P1, we call it, okay? P2 is the patient with mild systemic disease. You could have somebody who has diabetes, but it is well controlled. You could have hypertension, is well controlled. That is ASA 2. ASA 3 is a patient with systemic disease, but poorly controlled. All right, his diabetes, sugars are not well controlled. He's ASA 3. ASA 4 is a patient with severe systemic disease that is a constant threat to life. So somebody who's got a myocardial infection recently, all right, and you want to operate him, and it's a threat to life. So that's P4. P5 is a moribund patient who is not expected to survive without the operation. So somebody comes with a road traffic accident, all right, and he's in a critical condition, and you take him to theater and you want to operate him. He's got a ruptured spleen, he's got a long femur bone fracture and all those things, okay? And P6 is a brain dead patient whose organs are being removed for donor purposes, okay? Now, if you look at the mortality risk associated with anesthesia and surgery, ASA 1, the mortality is 0.1%, okay? ASA 2 is 0.2%. That's easy to remember, okay? ASA 3 becomes about 2%. So it rises to 10 times, or 9 times to be precise, from 0.2% to about 2%, from 2 to 3. So the best patient to operate is a normal healthy patient. You will lose 1 out of 1,000, okay? Or you may have complications 1 out of 1,000. If you're the patient P2, is 2 out of 1,000, okay? But then If you have ASA3, that means the patient with a systemic disease, diabetes, hypertension, or another disease which is poorly controlled, his anesthesia and surgery risks rises to 18 out of 1,000. You can remember as 20, okay, 2%. Okay. Now you look at a patient who has got severe systemic disease, and that is a threat to life. His risk is 7.8%, roughly 8%. So it becomes 4 times. Okay. And then an moribund patient who is not expected to survive, his anesthesia and surgery risk is about 10%. Next slide. Okay, so again, this says ASA1 is normal. I'm trying to repeat this so you remember. Easy way. ASA1 is normal. ASA2 is a medical condition, but with good control. The guy is a diabetic, hypertensive, he's taking his medicines, his BPs are normal, his sugars are normal. Okay, his HbA1c for the last 3 months have shown us good sugar control, so that's all right. ASA3 is patients with associated medical conditions, but they're poorly controlled with their med drugs. ASA4 is systemic disease threat to life, and 5 is moribund patient. Next slide. Again, to emphasize, easily, 0.1% with 1, 0.2% with 2, 2% with 3, 8% with 4, and 10% with 5. These are ballpark figures, easy to remember. Next one. Okay, now the ASA physical status classification was designed as a measure of preoperative health status, not operative risk. So you're looking at what is the preoperative status of this patient. Okay, this study found good results with how different anesthetists rate a patient's AS. So it can be transformed from one hospital to the other hospital if people follow it accurately. Okay, this study used psychometric methods to show that the ASA classification is an indicator of perioperative risk. Okay, so that is reliability. It is reliable. It can be used across the world if applied properly. Next one. Okay, anesthesia plan and consent. We're coming to consent now. Okay, if you're going to operate a patient, you need to take a consent. If you don't remember anything from this lecture, remember how to take a consent. A valid consent implies that it is given voluntarily by a competent and informed person who is not under duress. That is the most important thing, okay? That the patient gives you his consent to operate him voluntarily. He is competent. He has been informed about what it pertains to, okay? That sort of a thing. In emergency situations or in an unconscious patient, consent may not be obtained and the procedure carried out in the best interest of the patient. But in the best interest of the patient is most important. And then there is a Gillick competence. Those under 16 years who demonstrate the ability to appreciate the risks and benefits fully may be deemed competent. Okay, so you can take consent from a 16-year-old underage. Usually consent is from adults. Otherwise, their consent, the children's consent are given by their guardians. Next slide. So, preoperative preparation, we've talked about consent, we've talked about vitamin K, colon prep and antibiotics. I'll come to that later. Input, output, out, I'll come to that later. Let's look at consent. Next slide. You need to understand this and master this and remember this if you're going to be a good doctor. Okay, if you want to be a good doctor, then you need to remember led to reason. Led to reason is the mnemonic. Led in. Introduce yourself and identify yourself to the patient when you're taking a consent. That is L. E stands for explore. How much does the patient know about the condition? Inform him. If this is a hernia, it is not a life-threatening condition if or until it gets obstructed. When you could get obstructed hernia with intestinal obstruction, then it would be life-threatening. So explore and find out how much does the patient know. Diagnosis. What's your diagnosis and why the operation is being proposed? So that's the LED. 2, TO, treatment. What treatment are you offering the patient? Explain whether the treatment proposed is in accordance with the protocols, and if not, why. Options. Discuss all the options, including that of doing nothing. Use lay language. You can't use medical words. So if there is a medical treatment for the condition, you tell the patient, you don't need to have this operated. If he has a peptic ulcer disease and it can be treated with triple therapy, you don't need to do a vagotomy drainage. So you have to discuss all the options. Then you come to reason. Results. What are the likely results? Eventualities. Okay. The possibility of needing to remove the testicle in a hernia operation is an eventuality. So you may mention that. Adverse events, myocardial infarction, stroke, embolus, bleeding, and specific damage. Sound mind. Ask if they have understood. The patient must be competent, must understand what you're telling him so that he can give an appropriate consent. Open question. Check if other clarification is needed. So ask the patient, do you understand? Are you clear in your mind is what we are going to do? If not, do you have any questions? And notes. The last one in the reason is N. You must document everything discussed and agreed with the patient. You will find this doesn't happen at Kenyatta National Hospital. You are the guys to bring about change. Bring about this change and make sure that you take at least consents from 50 patients before you become a doctor using the acronym LED to reason. Next slide. Particular problems in elderly population which impact on surgical care include. So elderly patients, if you don't make the right decision, all right, you're going to be in problem. So if an elderly patient presents to you, delay in surgical treatment due to a missed or delayed diagnosis secondary to an atypical presentation. For example, the patient has acute appendicitis, cholecystitis. When you become elderly, 1/3 will not depict the disease with fever, they lack fever. 1/3, the neutrophilia will come late. And 1/3 lack the physical findings of peritonitis. So in elderly patients, when you're dealing with them, you have to be careful. Postponement of needed elective surgery because of misconception that an elderly person will suffer a poor outcome, thus increase emergency surgery rates, which carry 3 to 4 times mortality risk. So you have to be careful about in the elderly. Next one. Physiologic age. Physiologic age is different from your actual age. If you're an active person, all right, in your class, some people who are 25 years old may appear as if they are 18 if they exercise regularly and this thing. So you have to compare the physiological with the chronological age. The hallmark of physiological aging is 70 years. If anybody is over 70, then he is to be regarded as frail. Frailty is a syndrome associated with advanced age and results from decreased functional reserve. So his heart may be weaker. He may not be able to take a fluid bolus of 2 liters. Okay. He may have a different response with his respiratory system. Right? So these are the things which his kidneys may not be able to respond to high volumes of fluid and not throw out the urine. So they may have weak kidneys, weak heart, weak lungs. You've got to be careful about that. Next slide. The frailty score is more accurate representation of the patient's physiologic age. Okay. Pre-operative frailty, disability, and comorbidity scores are significant predictors of outcomes of the geriatric patients. So in elderly patients, you have to follow these things, okay? You have to follow how the elderly patients will present, what are the comorbidities, and you need to be careful when you're operating them. Next. Frailty, cognition, all right? His brain function, okay? Will tell you if he has fallen in the last month, his albumin is less than 3.3, his hematocrit is less than 35, disability, what is his activity during living, and comorbidity. So these are various scores used to identify patients at risk. Next slide. Checklist for optimum preoperative assessment of geriatric surgical operation. I am concentrating all the older patients because in Kenya, the average age is rising. The number of patients we will be operating in the near future will be elderly patients. So in addition to the history and physical examination, the following should be done. Cardiac evaluation, nutritional assessment, and cognitive assessment, okay? There are various tools used for this, and you need to follow this. Next one. Perioperative drugs in the elderly, okay? Use BS criteria. There's a criteria. Check it out on Google, okay? Drugs to avoid include antihistamines like chlorpheniramine, okay, nifedipine, zolpidem, and chlorhexazone. So these are common drugs which are in use, and you want to avoid these in the elderly because of the side effects. I'm not going to go into details about this. They can create confusion, myocardial ischemia, they can cause falls, okay? You need to avoid these drugs in the elderly patients. So check out these drugs. Next one. The normal fit patient, as I mentioned, Harshil Patel, a 25-year-old coming for an inguinal hernia, usually the world will say you need to do a full blood count, okay, and then operate. I personally believe that you don't need any investigations if you've done a thorough history taking, physical examination, and the patient is normal and fit. But generally, you do a full blood count and urinalysis for sugar, okay? If a patient has a low HB, but it is chronic low HB, maybe he has thalassemia trait and his HB is 8, it's okay if you're not going to lose a lot of blood, you can operate it, okay? Physical age as compared to chronological age, we discussed about that, 45, 50 or above. If a patient is above 45 or 50 in Kenya, you need a full blood count, you need urinalysis, ECG, chest X-ray, urea electrolyte creatinine, and blood sugar. These are the baseline investigations. Then if he is jaundiced, you need INR, platelet count, and all that. If he has got other problems, then you need other investigations. But this is a basic guideline of what investigations you need. Next slide. Pre-operative preparation, ASA2, all ages associated with well-controlled medical condition, they should have the full works of investigations. So if you have a medical condition, diabetes, hypertension, or things like that, you're not a fit ASA1, then you need all the investigations. Next slide. Diabetes, common, very common. In Kenya, half the diabetics walking around do not know they have diabetes. Remember that, okay? So we know people who are diabetics, but from the rest of the population, of those who are diabetics, half of them don't know that they're diabetics, okay? So requirement for oral hypoglycemic agent, one drug, glibenclamide, no insulin, glibenclamide, high dose, you require insulin. So these are guidelines of how you manage them during surgery. Next slide. ASA3, poorly controlled patients. A patient has hypertension, he's taking his hypertensive drugs, but his pressures are still 160, 110, 160, 100, things like that. You need to admit them earlier to control. If they have diabetes, bring the sugars in control. If they have hypertension, bring the hypertension in control. If they have asthma, get rid of the wheezing in the chest with nebulized Ventolin and things like that. The message here is when you operate a patient, get him back to normal as you can, and then you operate him. So if he's a diabetic, bring his sugars to normal, then operate him, right? So you got to admit them earlier, get them to control their associated medical condition, then you operate them. Next slide. Okay, intra-operative urinary output is very important for old patients, in patients with obstructive jaundice because of hepatorenal syndrome, and input-output control is required even post-operatively. Okay, so one of the things that determines how well your circulation is functioning, and you know circulation is very important, is your input-output charts. If you have a reasonable amount of input and a good amount of output, then your circulatory system, you can say, is functioning well. So this urinary output and input-output charts are very important. This is totally neglected. That's why I'm highlighting this. If you're operating at our hospitals, you'll find nobody checks what is the urine output after every hour in surgery. All right. Every hour, the patient should produce between 30 and 50 mils of urine. A normal adult male should be producing 30 to 50 mils per hour. Right. Next slide. So intra-arterial pressure. Now, intra-arterial pressure is a very good monitor in patients having major surgery, especially if the patient had poorly controlled hypertension before, if he's going for cardiac surgery, major neurosurgery, or pheochromocytoma surgery. These are certain invasive monitors that we have during surgery, during the operation, so that patients do well. Okay, you could be taking the blood pressure, but an intra-arterial pressure is much more accurate and better than blood pressure. Next one. Patients with comorbidities, they could have hepatobiliary disease. I mentioned jaundice, they could have other hepatobiliary. So diabetes, we've concerned. There can be other endocrine disorders like pheochromocytoma, asthma, we mentioned under pulmonary disease, ischemic heart disease, you need a cardiologist to guide you, renal disease, you need a nephrologist to guide you, CNS disease, neurosurgeon and neurologist to guide you to help with the comorbidities. You want to convert the patient as normal as possible before you operate him. Next slide. Obstructive jaundice, I'll repeat that because it's common in Kenyatta National Hospital. In the pre-operative preparation, you must give vitamin K so that the INR comes to between 1 to 1.5. The normal INR is 1. Up to 1.5 is accepted and acceptable. So you need to give vitamin K till the INR comes to between 1 to 1.5. IVI, intravenous infusion, is important in these patients because of hepatorenal syndrome. They need to be passing adequate amounts of urine so their kidneys don't suffer with the jaundice they have. And jaundice patients have a higher chance of getting infections, so you need to cover them with appropriate antibiotics. Next slide. Colorectal surgery. If you're doing colorectal surgery, there are various papers that came out saying mechanical bowel preparation is not necessary. It has been turned around, okay? Mechanical bowel preparation is mandatory, okay? And there are two types of preparation: mechanical bowel preparation and antimicrobial preparation. It is always safer to act safely. So you would prepare the bowel, which means clean out the bowel. There are various ways to clean out the bowel. You give them laxatives like Dulcolax, Senocort, and all these other laxatives. Plus, you wash the patients out from below with soap water enemas and Animax and suppositories like Dulcolax and glycerin suppositories. But you need the colon to be empty, no stool in the colon, and that's for what mechanical bowel preparation is about. Because stool contains bacteria, and if you operate with bacteria present and open those areas, you're likely to get infection. So your bowel should be clean. The other recent methods of mechanical bowel preparation we don't use are Golitelli or Golightly, all right, or whole gut irrigation it is called. So you take a balanced electrolyte solution, you put an NG tube, let the electrolyte solution flow into the patient's stomach through the NG tube. It goes to the small intestine, large intestine, and when the patient feels like opening the bowels, he sits on a commode, and what is coming out through his anus is clear solution, the one that you're putting in. That means there is no more stool and everything comes out. Then you need antimicrobial preparation. You need to cover anaerobic, gram-negative, gram-positive bacteria in colorectal surgery. Next slide. So for wound sepsis, pre-operative preparation, wounds are classified as clean wounds, clean contaminated wounds, and dirty wounds. A clean wound, for example, if you're doing a laparotomy, is when you open the abdomen, you don't enter the biliary tract, you don't enter the GI tract, you don't enter the urinary tract. You open, you find that there was a lipoma, you remove the lipoma, close the abdomen, all right? And that's a clean wound. A clean contaminated wound is you open the abdomen, you find some inflammation, for example, acute appendicitis, okay? A clean contaminated wound is when you open a tract, but there is minimal spillage. So you're doing a vagotomy drainage and you suck out the contents from the intestine, there is no spillage. That's a clean contaminated wound. A contaminated wound is when there is inflammation present, and a dirty wound is when there is pus present. So just to remind you again, a clean wound is when you go into the abdomen, you don't find any pus, any inflammation, you don't open any tracts, that's a clean wound. Clean contaminated wound, you open tracts, but there is minimal spillage. Contaminated wound is when there is inflammation present, and dirty wound is when there is pus present. For example, if you got the appendicular abscess, that's a dirty wound. Acute appendicitis without pus, inflammation present, that's contaminated wound. So you need to know about these and what antibiotics to give. Usually we use prophylactic antibiotics for clean contaminated wounds. Contaminated wounds and dirty wounds need therapeutic antibiotics. So according to the bacterial flora, you'll give the antibiotics. Next slide. Antibiotics, as I mentioned, can be prophylactic or therapeutic. So clean contaminated wounds, we use prophylactic antibiotics, which will be single dose or 3 doses, all right? And it depends on the surgery, the duration of surgery. If the duration of surgery is long, greater than 2 hours, or if the blood loss is high during surgery, 500 mils, then you need prophylactic antibiotics. Therapeutic antibiotics, you all know about it, okay? Usually there's a course of antibiotics given for therapy, and that's what you need to read about. Next one. So post-operative care. In the post-operative care, there are various things which are important. One of the most important thing is input-output chart. I mentioned to you, the patient is usually given an input of between 2 and 3 liters a day, and then his urine output should be about 30 to 50 mils per hour in the initial stages, and per day, you're talking about urine around a liter, okay? Pain management is important. If the patient has had a laparotomy, then potassium supplements becomes important. because the patient is not feeding and his daily requirement is 80 milliequivalents of potassium a day. So he should get these 80 milliequivalents of potassium a day through the parenteral route, intravenous route. Antibiotics, according to what surgery you have done. If you've done colonic surgery, then you need to cover gram-positive, gram-negative, and anaerobic antibiotics, okay? Feeding is important. In the post-operative period, you can feed with about 5% dextrose, okay, which gives you 200 kilocalories per liter. So if you're giving 5% dextrose, 2 liters, okay, or 5% dextrose, the patient is getting 400 calories. That 400 calories is okay for up to 3 to 5 days if the patient his metabolic rate is low. But if he has a fever and metabolic rate is high, then he needs TPN and things like that. Okay, feeding is important, antibiotics are important, potassium is important, pain management is important, IVI is important. And then physiotherapy becomes important. You need to look at the chest. If you've done a laparotomy, the abdominal wound causes pain, the diaphragm does not move, the lungs collapse at the lower lobes, and you get atelectasis and pneumonia. So breathing exercise is very important. You need to take care of DVT. So if the patient is not moving, early mobilization is very important. But if he's not moving, then you need to make sure that he's hydrated well and DVT prophylaxis is present. Next one. Other things in post-operative care which are important, the patient may have an NG tube, care of the NG tube. He may have drains. How, when, where, what drains are there, and when do you remove them? You need to read about that. Wound care, I mentioned DVT prophylaxis. I mentioned atelectasis. Atelectasis is the commonest complication after a laparotomy. Atelectasis is collapse of the basal alveoli of the lungs because the diaphragm does not move because of pain in the abdomen. So pain management is very important. Physiotherapy is very important. Chest care is very important. I've talked about feeding and early mobilization. Next slide. That's the last slide. So thank you very much. I see there are under 50 people and you're supposed to be 200. So that tells me how important I am at giving a lecture to you guys, which means it's not very important. Then next time I may not come to give this lecture. Ashil, any other comments, questions or chats from the people? Let's see what's going on. So how many have listened to this lecture? Okay, then it's a little bit reassuring because otherwise it was a waste of time for me if you guys are not interested in. I mean, these are important things that we do, and I don't want to feel as if I'm wasting my time. Anyway, it's good. So thank you for any questions. Put them on the chat if there are any questions so we can answer your questions. Thank you very much, Ashil. Have a nice day.
You too, bro. Have a nice day.
Thanks and bye.